Welcome to From the Experts, All Things Celiac. Today's webinar is Close Connections in Autoimmunity, Thyroid Disorders, and Celiac Disease, hosted by the Harvard Medical School Celiac Education and Research Program and the National Celiac Association. The Harvard Medical School Celiac Education and Research Program was founded in 2013 by celiac experts from the three Boston hospitals: Dr. Alan Leichner of Boston Children's Hospital, Dr. Karen Kelly of Beth Israel Deaconess Medical Center, and Alessio Fasano of Mass General Brigham Health. This highly collaborative Harvard Medical School program has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. I'm Lee Graham, Executive Director of the National Celiac Association, celebrating our 30th year serving the gluten-free community. National Celiac provides educational resources on our website like Ask the Dietitian, Raising Our Celiac Kids, and Supporting Celiac Seniors. We have over 65 support networks across the country, and Zoom interactive meetings are open to all on the second Tuesday of every month. And my thanks to all of you for your continued support of our food insecurity initiative, Feeding Gluten-Free. Thanks to you, we are now delivering gluten-free food to food pantries in over 3,000 communities across the United States. After 28 years of involvement with NCA, I am stepping down from the position of CEO and Executive Director. It is bittersweet that I will miss all of you, but at the same time, we have a truly remarkable and very capable person coming on board. Chris Rich has over 10 years of experience within the celiac community. He is thoughtful, kind, energetic, and talented, and I'm honored and excited to introduce him to you. Welcome, Chris Rich.
Well, thank you, Lee, for that introduction, and more importantly, for your 28 years of providing for and supporting our celiac disease and our gluten-free community. You have certainly gone above and beyond. So as Lee mentioned, my name is Chris Rich, and I am the CEO and Executive Director of the National Celiac Association. I'm excited to be a part of these educational webinars, have the opportunity to work with this great team, and create connections with all of you in attendance. For today's event, you are welcome to ask general questions through the Q&A feature, which is located at the bottom right corner of your Zoom screen. Closed captions available by clicking on the CC button, also at the bottom of your screen. For those of you who have registered for continuing education units, please fill out the survey that will be added to the chat box during the webinar. If you're still struggling to connect with us, tech support is available if needed. You can email at digitalmedia@partners.org. That is digitalmedia@partners.org, or you can reach us by phone at 857-282-6470. This session is also being recorded and will be available for viewing on the National Celiac Association's website, nationalceliac.org. Our moderator today is Dr. Giuseppe Barbacino. Dr. Barbacino is an assistant professor of medicine at Harvard Medical School in Boston. He is a full-time assistant in the thyroid unit at Massachusetts General Hospital in Boston. Dr. Barbacino's research interests have been mostly directed to the understanding of the genetics of thyroid autoimmune disease, clinical aspects of thyroid cancer, and the clinical performance of immunoassays. As a full-time faculty member of the thyroid unit, he is now mostly involved in the care of patients with hyperthyroidism, thyroid nodules, and thyroid cancer, and in the teaching of medical students, residents, and fellows within the Harvard Medical School system. So without further ado, welcome, Dr. Barbacino.
So thank you, Lee and Chris, and welcome everyone to this webinar entitled Close Connections in Autoimmunity, Thyroid Disorders, and Celiac Disease, a very important topic. As already mentioned, please remember to submit your questions only through the Q&A window in the Zoom. You can view the recorded session later on the NCA website, which is called www.nationalceliac.org, and CU will be available for registered dietitians, nurses, physicians, and social workers who have pre-registered for the webinar. To receive your CU, please fill out the survey that will be posted in the chat section during the webinar. And so without further ado, let me introduce the first speaker today, Dr. Ari Wassner, He is the medical director of the Thyroid Center at Boston Children's Hospital and an associate professor of pediatrics at Harvard Medical School. He earned his MD from Harvard Medical School and completed pediatrics residency and fellowship in pediatric endocrinology at Boston Children's Hospital. Dr. Wassner's clinical and research interest is in pediatric thyroid disease, including internationally recognized expert in pediatric thyroid disease. He has written numerous research articles, reviews, and chapters on all these topics, and serves on clinical guideline committees for the American Thyroid Association, which is the foremost association for thyroid disease in the United States, and the American Academy of Pediatrics. He has been a contributor about thyroid disease and celiac disease to the Boston Children's Hospital Raising Celiac podcast. Dr. Wassner also directs the endocrinology fellowship program at Boston Children's Hospital and is extensively involved in medical education and curriculum development at Harvard Medical School. Dr. Wassner will talk to us today about connections between thyroid and gut autoimmunity. Ari, please, up to you.
Thank you, everybody. Thanks, Giuseppe, and thank you to the whole organization for inviting me to share this time with you today. I hope this will be educational for all of us. So I'm going to just launch into the first part of this talk, which is going to be focused on the association between thyroid disease and celiac disease. These are a couple of my authorship disclosures, which are not going to be relevant to today's talk. So I'm hoping that by the end of this session, we'll be able to get you through these sort of 4 key questions about the association between thyroid disease and celiac disease. And that you'll be able to sort of feel comfortable with some of these questions. So the first is, first of all, what's the basic relationship between thyroid disease and celiac disease? How are they related? In patients with celiac disease, how common is it to develop thyroid problems? And with relation to that, how and if and when should we be testing for thyroid problems in patients who have celiac disease? And then I'll conclude just by saying a few words about what may be done to reduce the risk of thyroid problems in those who already have celiac. I'll also just say as a caveat, so I'm an endocrinologist, pediatric endocrinologist, and a thyroid doctor. I'm not a celiac expert, so I know a bit about the relationship between the two, but I'm coming at this from a thyroid point of view. So if there are questions about, specifically about sort of management of celiac that's not thyroid related, we may have to call on some help for some of those things. But the thyroid I do know a little bit about. So just to get us all on the same page to begin, let's think about what the thyroid is and what it does. So this is the thyroid. It's a sort of butterfly-shaped gland that lives in the front of the neck. Its only job in life is to make this hormone, this chemical called thyroid hormone, which is also known as by a chemical name thyroxine or T4, which you may see in lab tests. And this hormone goes around the body and it has a lot of very important effects on almost every organ and tissue in the body. It's very important for your cardiovascular system. It affects how fast the heart beats, how hard it beats, blood pressure, cholesterol. Thyroid hormone is very important for the brain and the neurologic system. So in children, it's critical for normal neurologic development and cognitive development. In children and older in adults, it's important for mood, how your body uses energy, metabolism, setting your body's temperature and metabolic rate. It's very important for the skeleton. So in children, it's critical for normal growth. Children who don't have enough thyroid hormone don't grow. In older children and adults, it's important for bone density. It certainly affects the gastrointestinal tract, how fast the intestines move. It affects many aspects of reproduction. So in childhood, it affects you going through puberty, developing into an adult, and later on, aspects of regulating the menstrual cycle and pregnancy. So it has a lot of very important effects. It's important that the levels of thyroid hormone be normal. So what happens if they're not normal? So we typically think of 2 different general categories of thyroid problems, hypothyroidism and hyperthyroidism. So hypo means too low, hyper means too high. Hypothyroidism is a lot more common. But if you think about what are the symptoms, you can think about thyroid hormone as sort of setting the overall rate of a lot of body processes. So when you have low thyroid levels, things tend to slow down, right? So in hypothyroidism, you may have fatigue, low energy, may have not a lot of motivation, sometimes depression. Growth, if you're a child, will be slow. The heart beats more slowly. It doesn't beat with as much vigor. You have decreased metabolic rate, so you may have weight gain. Your intestines don't move as quickly, so you may have infrequent bowel movements or constipation. So overall, things slowing down. Hyperthyroidism is the opposite. Things tend to speed up. So you may have tremor, fidgetiness, fatigue just from going a little too fast. You may have accelerated growth if you're a child, low bone density from increased turnover of bones. Again, the heart beats faster, it beats harder, blood pressure may be a little higher. You may lose weight from increased metabolic rate, more frequent bowel movements. So these are just a general way to think about these symptoms. And as I said, hypothyroidism, so underactive thyroid, much more common than overactive thyroid. Now, if we think about kind of what causes these things, the common thread here is that the most common cause in both children and adults of thyroid problems is autoimmunity. And I'm going to now sort of turn to what exactly that means. So the most common cause is what we call autoimmune thyroiditis. So that just means autoimmune inflammation of the thyroid gland. This is a condition that's also called colloquially Hashimoto disease. You may have heard that term. So we're going to talk a little bit about what that is. So we all know that the body has an immune system, right? Its job is to fight off infections, invasion from viruses and bacteria. That's done by these lymphocyte cells, these white blood cells. And their job is to recognize if you have some kind of invading organism like a virus, this blue virus over here, you have a population of white blood cells in your body that recognize this specific virus. And when it comes in, these cells are going to go over and recognize that virus, and they're going to contribute to destroying that virus and protecting you from that infection. So autoimmunity happens when maybe you have some protein, some structural thing in one of your own organs, like a thyroid, that looks like part of one of these viruses, right? It's blue, just like the virus. And so this white blood cell may now get confused and say, wait a minute, there's this thing over here that looks just like a virus. I'm going to go over and attack that too. And so you may have a lot of these white blood cells that recognize and start to attack part of your own body. And the thyroid is a common place for that, and that gives us autoimmune inflammation of the thyroid, or autoimmune thyroiditis. And that's effectively what's happening. So over time, just like these things can destroy viruses, this inflammation can also destroy parts of the thyroid. And so if you have this inflammation for a long time, as your thyroid slowly gets destroyed, you may not have enough thyroid left to do its job, and your thyroid hormone levels may fall, and then you develop hypothyroidism over time. So you can have the inflammation, the autoimmune thyroiditis, but your thyroid still works okay until maybe over time enough of it gets destroyed and you eventually develop low thyroid function. So that's a useful distinction to think about. But that's the idea of autoimmune thyroiditis. Now, what's the connection to celiac disease? So as we know, both celiac disease and autoimmune thyroiditis are problems with autoimmunity, right? They're problems of immune dysregulation. So, most people don't develop either of those things. So in a typical person, each person has their own sort of complement of white blood cells. And in a typical person, this person, for example, doesn't have any white blood cells that are going to recognize this thyroid, and they're not going to develop autoimmunity. But there are some people who tend to develop autoimmunity, and they might have a complement of white cells, of which some have the potential to recognize this thyroid, right? They have a predisposition to develop autoimmunity, and they may develop autoimmune thyroiditis. For genetic reasons, these same people may have other white cells that have a tendency to recognize other things that they shouldn't, like perhaps gluten in the intestine. And they may also go on to develop celiac disease. So this is the connection between the two. People who tend to have this kind of autoimmune predisposition may be more likely to have one or the other, or both of these conditions, as well as a number of other autoimmune conditions that we're not talking about today. But this is essentially, in a sort of simple-minded way that I can understand, is how the relationship between thyroiditis and celiac disease works. So practically speaking, what does this translate into? So how common is it if you have celiac disease to eventually develop a thyroid problem? Certainly more common than in the general population, right? As we talked about, among people who have a predisposition. Exactly how common it is depends a little bit on what study you look at and how it's been looked at. So you can find numbers looking in the celiac population anywhere from some sort of like 1 to 30% of patients with celiac disease may have thyroid problems. It really depends on how you define the celiac population, how you define the thyroid disease. This is a study that I like because it's pretty big. It comes from Sweden a number of years ago, but they looked at a very large population. In that study, they found thyroid disease in about 1.5% of celiac patients and only about 0.5% of people who didn't have celiac. So about a 3 to 4-fold risk of thyroid disease if you have celiac already. That's in adults. And in kids who have celiac, the risk of thyroid disease is even more increased, maybe 5 or 6 times. So that's sort of the how many fold risk. You can also look at it in terms of incidence, which is how likely are you to develop thyroid problems if you already have celiac over the next 10 years. In this particular study, it was about a 2% chance over 10 years if you had celiac and a little bit less than 1% if you didn't. And again, the overall rate's a little bit lower in kids, but the increased risk is greater. So that's kind of a general sense of numbers. Again, depending on the study, you could find numbers higher than this, but I think this is a good sort of population-based study. This is an even more recent, what's called a meta-analysis, looking at a very large population in the United Kingdom, many millions of patients, looking at the associations of different types of autoimmune conditions. So if you look here, this is celiac disease. So in people with celiac disease, their likelihood of developing Hashimoto thyroiditis or autoimmune thyroiditis is light blue. So somewhere in the 1 to 2-fold above the normal population without celiac disease. So this is another kind of way of looking at this. I'll just point out for interest, if you go the other way, right, if you have Hashimoto thyroiditis or autoimmune thyroiditis, the likelihood of developing celiac disease in this group was actually a bit higher, sort of in the 2 to 3-fold range. Clearly an association. So, knowing that there's a risk of thyroid disease in folks who have celiac, let's just say if we were going to check, and we'll talk in a second about whom should we check and when, but if we were going to test for thyroid disease, how do we do it? So in general, in thyroid world, the best test for checking for thyroid function problems is a TSH level. This is a thyroid stimulating hormone. So this is a level that goes up when your thyroid hormone levels go down. So they move in opposite direction. When your TSH is high, that means your thyroid levels are too low, and vice versa. This is the best single test for thyroid disease in this population, if you want to know if somebody's thyroid is working well. Now, that's because it's the most sensitive test. There are a lot of other tests that sometimes get sent, and I wanted to say a word about these because people frequently ask, what about thyroid panels, or what about T4s, or free T4s, or T3s, and these kind of things. So in my opinion, I would say based on the data that we have, these tests are generally not useful for screening. That is, if you don't have any symptoms, you're just checking to see if you might have thyroid problems. These tests are generally not that useful, and I'll tell you why. So these levels, sort of T4 levels or free T4 levels, they will tell you if you have thyroid dysfunction, right, how severe it is. But TSH is actually more sensitive for determining if there's a thyroid problem at all. So if you're just screening, TSH is really the most important thing. T4 or free T4 generally don't add that much at the beginning. T3 and free T3 are generally even less useful for thyroid disease because they tend to be maintained even when your thyroid function starts to go down. So I generally would not recommend checking these things, T3 and free T3. Reverse T3, I'll just say, from a clinical standpoint, is almost never useful in any situation. We very rarely use it. And we think people say like, oh, well, maybe it gives you more information and that's better. But in practical terms, it almost never gives you information that you can act on. So I do not order reverse T3s almost ever. These last ones, these AB stands for antibody, right? So these are TPO and thyroglobulin antibodies. These are tests that we do sometimes send. What these are testing for, these are blood markers to see if there is inflammation in the thyroid, right? This autoimmune thyroiditis that we talked about. So if you have this kind of inflammation, you often, almost always, will have these antibodies. And so you can use that as a diagnostic test. So that's a fine thing to send. But you have to think, like, what's the point of doing that, right? We talked about how you can have this inflammation, but not yet have thyroid dysfunction, right? Not yet have hypothyroidism. If you want to know if the thyroid is functioning, the test for that is TSH, which we're going to do. So if we want to know, do you have inflammation? That's nice to know, but we already know that people who have celiac disease are at increased risk of autoimmune thyroiditis. And especially if we're already going to be monitoring TSHs to see if their thyroid function is okay, it may or may not be useful to test these. You could test it, but if it's negative, you might still decide to check the TSH from time to time. So this is a thing that can be done. I think that's something to sort of talk about with your doctor, whether it's worth it or not. Is it going to change what you do? But that's what these tests are, and why in general, I don't typically test any of them other than TSH when screening. So as far as when and whom should be screened, so I think it goes without saying, if someone has symptoms of thyroid problem, right? If you have symptoms of hypothyroidism or of hyperthyroidism, certainly we should be checking a TSH, right? We should be looking and checking the thyroid function, especially in someone we know is at risk. So just to remind you, this is kind of the list of those symptoms, and there are others, but remember the slowing down and speeding up. So these symptoms, if you have them, might be a reason to check thyroid function. I'll also just note, by the way, some of these symptoms you can imagine potentially overlapping a little bit with celiac, right? You have some GI symptoms, you have to be a little bit thoughtful about that. But in general, if there are symptoms, clearly we should be checking. The bigger question, I think, is what about people who don't have symptoms, right? Should we be checking in people who have celiac but don't have any clear symptoms of hypothyroidism? So this is where I'm going to go out a little bit out of my comfort zone, because I'm not a celiac specialist. But in pediatrics, at least, as I read it, the national guidelines for celiac disease do suggest screening for thyroid disease in children with celiac when they're diagnosed with celiac, and then once a year, because we know their risk is significantly increased. In the adult population, I didn't see a formal recommendation from the celiac sort of guidelines that adults with celiac need to be tested, but they do say consider. So, and I think my sense is that many adult gastroenterologists and those who care for celiac disease, many are testing on a regular basis, but I didn't see a formal recommendation one way or the other. So certainly something to talk about with your doctor who's caring for your celiac disease, whether screening is worthwhile. As I said, we know that the risk is higher. And then lastly, I just want to get to this question about, what do we do about this risk, right? We know if we have celiac disease, we know that we're at risk for thyroid problems greater than the population. Is there anything that I can do to try to reduce the risk of that happening? So this is going to be a little bit of a bummer, but the short answer, unfortunately, is there's really not that much that we know of that can reduce this risk. That's the top line. There's a lot of discussion and question about what about a gluten-free diet, right? Gluten-free diet certainly is necessary for celiac to treat the celiac disease and the gastrointestinal issues. You might think that by reducing kind of overall body inflammation, could that reduce autoimmune inflammation of the thyroid? And that's a reasonable thing to wonder, but it turns out that in practice it doesn't really make much difference. So this is kind of a fairly recent systematic review looking at a number of studies trying to see if gluten-free diet for celiac disease reduces the risk of autoimmune thyroid disease. And basically it doesn't seem like there's any good evidence of that at the moment. And this is true, by the way, for those who have sort of non-celiac gluten intolerance or gluten sensitivity. Not really any evidence that maintaining a gluten-free diet will prevent you from getting thyroid disease. So these probably are just sort of, as we talked about, independent autoimmune events that happen in people who are predisposed, but treating the celiac with gluten-free diet doesn't really affect the course of the thyroid disease. We often get other questions about different kinds of diets, whether in celiac disease or otherwise, for thyroid health. What about iodine, too much, too little, different kinds of supplements or diets or restrictions or vitamins? And just to sort of make a long story short, for better or worse, there's really not any good evidence that any of these sort of special diets have any significant effect on reducing the risk of developing thyroid problems or how severe the thyroid problems are, if you have thyroid problems, making them any better. So on one hand, you could see that as sort of a sad thing that we don't have any dietary ways of improving thyroid disease, either risk or severity. On the other hand, you could see it as it's not something you have to worry about, right? I know Giuseppe's smiling, so I'm borrowing this from him a little bit. But I think that you don't have to worry that something that you're eating is making your thyroid disease or your risk of thyroid disease worse. So that's maybe a little bit liberating. So that's the story as far as that goes. And I'll just wrap up then with a couple of kind of high-level points that I hope maybe you'll take away, and I hope we'll have some discussion later on. So hopefully I've convinced you, certainly thyroid problems are more common in individuals who have celiac than in those who do not, because of this underlying autoimmune predisposition. Particularly hypothyroidism, much more common than hyperthyroidism. And unfortunately, we don't have any good ways of specifically reducing that risk of thyroid disease in the celiac population, at least that we know of at the moment. Since we can't really modify it, but we know it's there, the way we address the risk is by keeping a close eye, looking out for symptoms and testing if there are symptoms. And in those who don't have symptoms, perhaps screening. Certainly in children, screening is recommended, and in many adults, it's certainly done. I think that, in my view, certainly is reasonable. So these are the things to keep in mind as you're looking to diagnose thyroid problems in folks with celiac disease. So I'm going to stop there and turn things back over to Dr. Barbacino and to Dr. Hennessey to talk a little bit more about diagnosis and treatment.
Thank you, Ari, for that comprehensive overview, and in the limited time, that was really great. And there are some questions in the question and answer section. If you can answer some of them, as time will not allow for all of the questions to be answered, but otherwise we can address some of them later. But now I would like to introduce to you Dr. James Hennessey. James is a director, or Jim rather, is the director of Clinical Endocrinology at Beth Israel Medical Center. He is an internationally recognized expert on the clinical management of thyroid disease and thyroid hormone replacement therapy. He's an associate professor of medicine at Harvard Medical School. He graduated from the medical faculty of the Karl Franzens University in Graz in Austria. As a fellow at the Walter Reed Army Medical Center, he worked on developing an innovative protocol to assess the relative equivalence of hypothyroid treatments, which led to his extensive work in thyroid hormone replacement therapy. Before coming to the Beth Israel in 2006, Dr. Hennessey served in the United States Air Force for 25 years, including his appointment as flight surgeon with Rhode Island Air National Guard, concurrent with his appointment as an endocrinologist at Brown Medical School and Rhode Island Hospital. He has discovered during his career several patients who have had celiac disease in the course of thyroid hormone management, and the way he found them out is that they required excessive doses of levothyroxine to correct their hypothyroidism. He has observed normalization of thyroid function following dietary intervention and has been able to reduce thyroid doses to normal amount. Dr. Hennessey today will deliver an update on the clinical aspect of thyroid disease in the context of celiac disease. Jim, please.
All right. So thanks for the invitation, etc. That was quite an introduction. And today's presentation is about thyroid disease with some reflections on celiac. And it was just put together as of very recent. So I do some consulting for thyroid hormone manufacturers. These three companies manufacture levothyroxine, desiccated thyroid extracts, as well as T4 and T3 product combinations. And so I am equally exposed to all sorts of different kinds of thyroid replacement therapies. And we can't really go in depth in this presentation, so we're only going to be hitting the highlights. So basics when it comes to thyroid disease and celiac is starting now from a celiac perspective, because that's what most of the literature is based on. And it's been associated with numerous endocrine disorders. As you know, thyroid is only one of them. Celiac patients may develop type 1 diabetes, or primary adrenal insufficiency, or vitamin D dependent osteomalacia, or secondary hyperparathyroidism, also from vitamin D deficiency. They can develop iron deficiency. Ovarian and testicular failure may be associated with it, as well as autoimmune hypopituitarism. Last but not least, thyroid disease, both hypo and hyperthyroidism, actually is the association that is said in several different reviews to be the most prevalent associated with celiac. So when we look specifically at autoimmune thyroid disease and celiac disease, the meta-analysis from Roy et al. In 2016, interestingly, looked at over 6,000 patients with autoimmune thyroid disease. Now, this switches the camera around the opposite direction. Let's start with patients who have autoimmune thyroid disease and see how much celiac we find in them. They had a subpopulation of 1.6% of these people had biopsy-proven celiac disease. So that's a fairly high standard above and beyond the autoimmune markers. And the prevalence among children was far higher than among adults. So as Dr. Wassner was telling us, children is really where it's at to be starting to make these diagnoses. Among those who had thyroid disease and celiac, hyperthyroidism accounted for about 2.6%. In this particular series, hypothyroidism 1.4%. And the end analysis with this particular meta-analysis was that about 1 out of 62 patients with autoimmune thyroid disease had biopsy-proven celiac. And this is why you come up with these recommendations where, well, with the majority of patients, should we or should we not be hunting for celiac if they have no symptoms? So let's start with a couple of cases. Maybe you recognize your grandmother here. And this 72-year-old, your grandfather, this 72-year-old man comes in with palpitations. That's a rapid heartbeat over the preceding 2 months. And he's suffered a 14-pound weight loss over 6 months. Most of you would recognize weight loss as a potential symptom of celiac disease. And recently, he's not sleeping well at night. He's got a blood pressure, which is reasonable, but a little bit higher than textbook. He's got a rapid heartbeat, and it's a bit irregular. He is staring right at you, and he's got a diffuse enlargement of his thyroid, and it's freely movable up and down. When the physician looks at his heart function a little bit more closely, he finds that it's very irregular, but there's no murmurs, gallops, or rubs found, and his lungs have a little bit of congestion in them, and that goes along with the little bit of edema that he has in his ankles. So what additional workup is needed with a patient like this? And I'll have to admit to you that I use these slides with physicians also. Well, certainly looking at his ECG to accommodate a diagnosis of atrial fibrillation with a ventricular response of about 110 beats per minute. But at the same time, because of the elevated size of his thyroid, the clinician is thinking, could this be a thyroid issue? So just like Dr. Wassner told us, you start with a TSH. It's a good screening test. And in this particular case, the TSH is undetectable, very, very low, indicating that perhaps when we look at further thyroid function tests, they will be elevated. And indeed, that is the case with the free T4 assay at 2.1, higher than normal, and the T3 assay at 345, higher than normal. And by the way, the only real indication for measuring a total T3 or a free T3 is when you suspect or are trying to confirm hyperthyroidism. So another term for hyperthyroidism is thyrotoxicosis. And the reason thyrotoxicosis is a more generalized term is because not all cases of thyrotoxicosis are due to autoimmune thyroid disease. Certainly, they can all be classified into one form or another, and most of them can certainly have signs and symptoms. Now, what we call overt thyrotoxicosis is associated with thyroid function tests indicating that the TSH is suppressed, probably because of the elevated free T4 and T3 levels. On the other hand, there's a form of thyrotoxicosis which we call subclinical, and that's when only the TSH is suppressed, but the free T4 and T3 levels are in the normal range. Etiology means what's causing this problem. And the number one cause of thyrotoxicosis from an endogenous or from the individual's state is Graves' disease. And as we have alluded to, Graves' disease is the autoimmune type of hyperthyroidism, and it's caused by stimulating TSH receptor antibodies which drive the uptake of iodine, the synthesis of thyroid hormone, and release. Now, the other kinds of thyrotoxicosis that may lead to this will be seen a little bit more frequently in older people, although Graves' disease is still the #1 reason. And it's called a toxic nodular goiter. And these are either multinodular or single nodules, and they have TSH receptor activating mutations that lead to excessive thyroid hormone production. These are especially dangerous if you're seen in the emergency room and have one of these multinodular goiters with a bit of autonomy, because you might get a contrast study, and that can induce a very severe form of thyrotoxicosis. Now, the third kind and most common kind are either painless or subacute thyroiditis patients. And this is the kind of overactivity that results in thyrotoxicosis that's caused by an inflammation of thyroid tissues and leads to thyroid hormone release. There's a painful type, which is not infrequently seen after viral infections, which lead to fever and thyroid pain. So a very painful thyroid might very well be painful subacute thyroiditis. Now, COVID-19 has led to a lot of cases of painful subacute thyroiditis being reported. And so it's just understood now that a painful thyroid in someone who's COVID positive probably means they have painful subacute thyroiditis. A painless type of subacute thyroiditis is also very common and happens to be autoimmune mediated. And it accounts for about 10% of the patients who we think are truly hyperthyroid. It frequently occurs postpartum after delivery of children, and is associated with various drugs as well as other types. This results in changing thyroid function test abnormalities, which get very confusing to both patients and primary care doctors alike. And the good news here is that it may spontaneously resolve to normal thyroid function if we just leave it alone. So this is a subacute thyroiditis course where we see over here the free T4 levels at the beginning are very high, as you can see. And then over the course of time, free T4 levels drop into the normal range. They may drop into the subnormal range, and then they tend to return to the normal range. The opposite is seen for the TSH. When free T4 levels are high, the TSH will be suppressed, and that looks just like Graves' disease. But over time, the TSH levels come up into the normal range as free T4 drops, and then they may actually be elevated when the free T4 levels are low, making it look like run-of-the-mill hypothyroidism. But if we just leave these patients alone, their TSH levels also normalize. So how do we determine what's causing the thyrotoxicosis that might be discovered in a particular patient? We can do something called a radioactive iodine uptake if they don't have clear-cut symptoms that are diagnostic of Graves' disease. Now, we typically don't do radioactive iodine uptakes in pregnant patients, and indeed in those with obvious signs and symptoms of Graves' disease, like Graves' eye disease, it is not generally recommended. We will add a scan to that to take a look at the function of individual nodules if we know that the patient has nodules, either by palpation or by other studies that tell us that there are nodules in that thyroid. So hyperthyroidism here splits out into two major groups. Now remember, we start with the suppressed TSH, and then if we do this radioactive iodine uptake test, then we could find that a group of patients have increased uptake of radioactive iodine. And if you think about it, if there's no TSH around, then the uptake of iodine should be practically zero. But we'll consider anything from 8 to 10% and greater to be increased. Now, where do we see this finding? Increased radioactive iodine uptake is seen in autoimmune mediated Graves' disease. It's also seen in hot nodules and multinodular goiters that are overactive. And we'll be looking at the scan to try to discriminate between those. It can also be seen in HCG, which is a hormone that comes out in pregnancy and has some other manifestations, as well as some very unusual cases of pituitary disease. On the other hand, what we're really looking for is absent uptake, so no uptake into the thyroid gland. And that will be seen with those cases of thyroiditis, as we were just talking about. It will also be the finding when we've gotten a big load of iodinated contrast in the emergency room and we can't measure the uptake because the body is flooded with iodine. It can be seen when we have exogenous thyroid hormone being given to the patient in the form of thyroid replacement therapies, or should I say over replacement therapies. And then if we're looking in the wrong place, we might find low uptakes if the thyroid hormone is coming from someplace like the ovary. How are we going to manage hyperthyroidism? And this is what primary care doctors get right on right away. They are going to provide you with symptomatic management by giving you what's called a beta blocker. And that's especially necessary for elderly patients, those with resting heartbeats greater than 90, and those who have coexisting cardiovascular disease. Anyone that has symptomatic thyrotoxicosis, no matter how old you are, should probably get a beta blocker to try to slow down the heartbeat and deal with some of the symptoms. Then we direct our interventions on the hyperthyroidism based upon the etiology. Again, what's causing the hyperthyroidism? Who should be treated? Those that have overt hyperthyroidism, remember those with elevated T4 and T3 levels due to Graves' disease, the autoimmune type, we can treat them with any of these treatments, either radioactive iodine, anti-thyroid medications, or if appropriately prepared, with a thyroidectomy. Those that have overt hyperthyroidism due to a toxic multinodular goiter or a toxic adenoma can also be treated with radioactive iodine or a thyroidectomy, and occasionally we'll be using anti-thyroid drugs, especially if people are living, for example, in a nursing home where it's problematic to treat them with radioactive iodine because of exposure to other people. How about subclinical hyperthyroidism? Do we need to treat them? Well, that's going to be based on the patient's age and their comorbidities. So if they have cardiovascular disease, for example, we're likely going to be treating them also. Let's move on to another case. We got a 53-year-old lady here who comes in with a 3-year history of cold intolerance, constipation, dry skin, and feeling very tired. For those of you taking notes, you will see that those are exactly the kinds of symptoms that Dr. Wassner told us to be looking out for a patient with an underactive thyroid. Now, over this period of time, her TSH levels have been in the 9.5 to 25.6 range, so they've been clearly elevated periodically over the past couple of years. When we talk to her in consultation, she tells us she's also getting very fatigued, she's got hair loss, and she's got facial swelling, which Dr. Wassner told us are all symptoms of hypothyroidism. This is the kind of patient that we need to be focused on and say, looks like you're hypothyroid, what should we do about this? And indeed, she's been online herself, and she thinks she needs to be on thyroid hormone replacement. And I think all three of us would agree that's probably not a bad idea. So hypothyroid patients, again, we've got two different kinds. We've got the overt kind, where we have an elevated TSH and a low free T4. Again, let me reemphasize, T3 levels have no role in diagnosing hypothyroidism. And they'll have nonspecific symptoms or very clear-cut symptoms and can have lots of cardiovascular and other manifestations. They're similar to the overactive thyroid group. There could be subclinical hypothyroidism with elevated TSH levels, but normal free T4. And they have little or no symptoms or very nonspecific symptoms, and they have clearly milder metabolic changes associated with the presence of slightly elevated TSH levels. So the etiology of hypothyroidism worldwide is probably still iodine deficiency, because not the entire world is living in an iodine sufficient environment. But chronic autoimmune thyroiditis, also called Hashimoto's thyroiditis, is the kind of problem that causes the vast majority of hypothyroidism in the first world. It's more frequent in women than men, and it increases in frequency with age. And that's a statement that you have to take with a grain of salt, because as TSH levels gradually increase with age, we can misdiagnose hypothyroidism in older people. Now, there's an iatrogenic form of this, which means due to some sort of medical condition or intervention, a patient is rendered hypothyroid, and that can be after radioactive iodine or after having their thyroid removed or irradiated for head and neck cancers, or certain drugs can also lead to hypothyroidism. A very uncommon form of hypothyroidism is called central hypothyroidism, and that's because the TSH, the pituitary hormone that regulates thyroid function, is no longer functional, and that can occur when there are tumors in that area or the effect of drugs, surgical interventions, or irradiation of the pituitary and hypothalamus. So when it comes to subclinical hypothyroidism, it makes us have to be a little bit more careful. Because remember, subclinical hypothyroidism is diagnosed initially when we find that there's some degree of TSH elevation in non-pregnant adults. The thing to do when we find one abnormal TSH is not to start therapy nor make any kind of diagnosis at that time. The thing to do is to confirm the presence of persistent abnormality. Now, if we can confirm the presence of subclinical hypothyroidism, we'll do that by repeating the TSH and getting a free T4 in about 1 to 3 months if the TSH is only mildly elevated. Now, some of you would think, oh, that doesn't look mild to me at all. It's like 3 times or 4 times elevated. That's mild elevation in TSH and can happen for multiple different reasons outside of real hypothyroidism. So with mildly elevated TSHs, we'll repeat it in 1 to 3 months. And if it's substantially higher, like greater than 15, we'll repeat the TSH with a free T4 in 1 to 2 weeks. So who then needs to be treated if they have subclinical hypothyroidism? And that is kind of a controversial area. So here's a review paper that was put out by Bernadette Biondi, and they have taken into effect what actually works and what will make people feel better and what is currently and reasonably indicated. So if we have patients that are under 65, and we're going to call the under 65s the young people, we are definitely going to recognize that when they have normal TSH, they will not need any kind of treatment. Now, this is something to take home with you. If you have normal thyroid function and all of those symptoms, your doctor should be looking for the real reason for your symptoms. It's not your thyroid. On the other hand, a younger person with a mildly elevated TSH, the next step after confirming that they have 2 TSHs that are in this range is to look at the thyroid peroxidase antibodies and look for the autoimmune propensity in that particular patient. Otherwise, we would simply annually repeat thyroid function tests in patients that don't have symptoms. And we might consider treatment with levothyroxine if they have multiple symptoms of hypothyroidism. There, I would basically say, be careful. These symptoms are so nonspecific that you may be disappointing both yourself and the patient when you do that. But the younger the patient is, the more likely it is with only a mild elevation in TSH that the symptoms could be due to hypothyroidism. On the other hand, consider treating if they have positive antibodies to prevent the progression to overt hypothyroidism. We could still consider just repeating and watching, but at the same time, it's not unheard of to have that kind of recommendation made. If they are progressively increasing their thyrotropin levels or TSH levels during that period of time, then considering treating that might be helpful. But definitely, if this is a younger woman who is planning a pregnancy, a TSH between 4.5 and 6.9 is not considered optimal, to say the least. Another weak consideration is the presence of a goiter, and indeed, a goiter may shrink if they're treated with levothyroxine. On the other hand, in patients that are over 65 years of age, for mild elevations in TSH, treatment is not recommended. And there's multiple reasons for this, but the first one to consider is your symptoms will never get better at that particular mild level of TSH elevation because your symptoms are probably not due to hypothyroidism. Now, when we move on to a somewhat higher TSH, 7 to just under 10, it's suggested that younger people be treated with levothyroxine to reduce the risk of stroke and coronary heart disease. And older people consider being treated with levothyroxine to reduce the risk of coronary heart disease mortality. There's some equivocal data that basically reinforces and underlines that particular approach. TSHs greater than 10 have been demonstrated to be effective in reducing the risk of progression, in helping with heart failure and cardiovascular events, as well as coronary heart disease mortality. But notice here that there's nothing about symptoms. So people with subclinical hypothyroidism, even if the TSH is greater than 10, are highly unlikely to reverse their symptoms with levothyroxine, especially if they're over 65. Who should we not be treating? We should not be treating patients that have hypothyroid symptoms and normal thyroid function tests. And to underline what Dr. Wassner shared with us, indeed, the reason to do thyroid function tests is to rule out thyroid disease. When thyroid function tests come back normal, the primary care doctor has more work to do to try to explain those symptoms. And that's based upon a placebo-controlled trial of people who had hypothyroid symptoms and normal thyroid function tests. What should we treat with? In general, the guidelines tell us that hypothyroidism should be treated with levothyroxine monotherapy. And indeed, the guidelines go on to tell us that combinations of T4 and T3 are not clearly shown to be more effective. What are the therapy targets for thyroid hormone replacement? Certainly replacement doses in this range, about 0.8 micrograms per pound, would be started at lower doses for older people, as well as people who have body mass indexes greater than 35, which are the significantly obese population. The elderly people, those with symptomatic coronary artery disease, we might actually start them very low, like 12.5 micrograms a day. The best outcomes with levothyroxine are when it's taken fasting with water only 60 minutes prior to breakfast. And that way we don't have interference from food on the absorption of the levothyroxine. Now, when we talk about excessive levothyroxine dosage being seen in primary hypothyroidism, typically those patients are being treated with more than 225 micrograms per kilogram. And they will be ruling out GI diseases as the first step of trying to explain this malabsorption. Now, things like autoimmune gastritis, as well as H. pylori and giardia can cause this. Lactose intolerance can cause this. Some of the levothyroxine preparations are indeed based on lactose. And celiac disease can cause this. And there are interventions in celiac disease that really improve upon this situation. Ulcerative colitis and Crohn's can also cause this because of small bowel malabsorption. So this is probably the primary area right here with celiac disease to be screened for when patients have very high doses of levothyroxine. Now, in addition to that, most of you are taking other medications like proton pump inhibitors or iron tablets or calcium or a aluminum or sucralfate, even some bile acid sequestrants, which are used for cholesterol treatments, and raloxifene, which is a treatment for osteoporosis and or breast cancer. All of these can retard the absorption of the thyroid medication, so none of them should be taken before 4 hours have passed since the levothyroxine was ingested, preferably fasting with water only after an overnight fast. Now, if you add soy or milk or coffee or breakfast within an hour of taking the levothyroxine, you can inhibit its absorption. So we can cause pseudo-absorption problems of levothyroxine by other medications. So when we follow up on these patients, once they've been started on levothyroxine treatments, the first TSH should be repeated in the minimum of 6 weeks, usually 8 to 12 weeks, to allow equilibrium of the thyroid hormone to have been reached with the daily doses of levothyroxine. And once they're at target TSH, which is within the normal range, then follow-up once a year is recommended. So I'm going to thank you very much for your attention, and I'll turn it back over to doctors.
Thank you, Jim, for that. Great overview as well from the clinical aspects. And we have a lot of questions. I see that Dr. Wasserman has been very active answering those in the chat. That's great. Thank you for that, because otherwise we would not have time. But let's go through some of them. Some of these things have been addressed already, and some of these questions were submitted in advance without knowing what the topic would be. But I have a question, for example, for Jim. We heard from Ari that we don't do a lot of screening tests, but what is your perspective of that? Especially with regard with reverse T3, there is a specific question whether reverse T3 has any use in testing for thyroid disease.
I would say unequivocally, only in the ICU and only under studies that are looking for verification of non-thyroidal illness. And in the ICU, essentially everybody has significant non-thyroidal illness, so I don't even recommend it then when we're called in consultation. Reverse T3 is a very popular test that can be ordered online on many websites. And unfortunately, when you read about the interpretation of reverse T3, it's sort of the opposite of what physiology tells us. So I don't use reverse T3 at all. It has no role in the diagnosis of hypothyroidism.
Thank you for that. And Ari, here's a tough question that was submitted earlier. So do you think that COVID and or COVID vaccines have increased the risk for intestinal and or thyroid autoimmunity?
Yeah, so yes, there's a lot, kind of a hot topic now. It's like COVID and autoimmunity, or what's the role? So I tried to look into this a little bit. I guess I would say, broadly speaking, it's not clear to me that there's any proven role of COVID or COVID vaccines in increasing autoimmunity broadly. It's certainly true that, as I think Jim mentioned, there are patients who get COVID who can get subacute thyroiditis, so they can get sort of an acute thyroid inflammation when they have related to the COVID infection. That definitely happens. But whether having COVID once then makes you more likely to develop, particularly hypothyroidism later, I haven't seen any good evidence of that. There is some data that there's some suggestion it might increase the risk of Graves' disease. I saw a couple of papers, but I think that's still not quite true. And I didn't see anything about prior COVID infection increasing the risk of celiac disease in the future. It's hard to know. It's still early days. There are sort of theoretical reasons to think, COVID increases inflammation. There's a lot of things going on inflammatory wise, but I don't think we have enough information to say for sure, but nothing obvious yet. That would be my summary.
Oh, okay. I got COVID comments too. Can I, Giuseppe, please?
Absolutely.
First of all, I looked into the association between COVID vaccines and autoimmune thyroid diseases. And it may not be cause and effect. It may simply be that with billions of people being vaccinated and case reports coming out saying, oh, well, this patient was vaccinated 6 weeks ago, and now they presented with tachycardia or with hypothyroidism or with thyroiditis. It may be just coincidental, and it's not necessarily really nailed down to be cause and effect. But the good news is, with all of the people that are presenting with autoimmune thyroid disease, maybe coincidentally after they've gotten a COVID vaccine, the treatment is exactly the way we would treat them. The diagnosis is exactly the same as we would otherwise treat them. And so I would not discriminate. I'd simply say, yep, looks like you got hypothyroidism. It may or may not be associated with your COVID vaccine. So up to you what you want to do with that information. But please, may we treat you and help you with this. So that's, first of all, the COVID vaccine. Secondly, long COVID. If you look at the symptoms of long COVID, 9 of the 12 symptoms of long COVID come right off the same list as the thyroid symptoms. So people with long COVID, especially older people who may have a mildly higher TSH than what the clinical laboratory says is expected for young people, may be misdiagnosed as being hypothyroid and having their symptoms attributed to hypothyroidism. So be careful. Long COVID is not being caused by hypothyroidism. Long COVID is long COVID, whatever that is. And be careful in the diagnosis and getting confused with mild elevations in TSH, especially among our 80 and 90-year-olds, where TSHs would routinely be 6 or 7 or maybe even 8 under normal conditions for normal thyroid function.
Great. Yeah, it's a very hot topic, and it's very important because there is a lot of vaccine hesitancy. So we need to know exactly what we counsel our patients.
Well, so I have one other comment about that then. All of the reviews that I read on vaccine and their apparent association with autoimmune thyroid disease are all based on case reports. And so we all know that there's a big bias in that. And with case reports and small series like that, you can't do cause and effect. But secondly, the bottom line of everybody's conclusion is, because the vaccines are so effective in preventing mortality with COVID, without a doubt, the thing to do is to get vaccinated.
Great. Thank you for that. Ari, you mentioned that there is no specific diet to prevent thyroid autoimmunity, but what about supplements? Are there any supplements that will help, as far as you know, because that's something that patients really ask about a lot, and so that would be your perspective on that would be very helpful.
Yeah. So as far as I know, there's nothing that's been robustly shown to affect thyroid function, right? People often ask about iodine, right? Iodine is important for the thyroid to work, but certainly a normal US diet has plenty of iodine, not too much, not too little. And so it's not something I typically tell people to worry about. I certainly don't have people take iodine supplements. Beyond that, there are people talking about selenium and these other kinds of things. But to my knowledge, again, there's no specific supplement that is clearly shown to make a difference in thyroid function. So you guys have a lot of experience with this too. So chime in.
Yeah, no, I agree with you on those two aspects. Spilling over into but does a low gluten diet help in any way? Well, with my patients that have had high amounts of levothyroxine replacement, once they've gotten on the low gluten diet and their celiac is better treated, the doses drop significantly. And I can always tell when they come back in and their TSH is drifting up, are you having a hard time with your diet? Oh, I haven't been following it very closely. Yeah, well, I can tell, because your dose of thyroxine is becoming less effective.
And then there are questions regarding family members, and there are two aspects of that. And I'll ask Ari first, and recognizing that you're not a celiac expert, But the question with family revolves around children often. So, is there any recommendations for testing first-degree siblings of people who have celiac disease, and what kind of tests should be done, and so forth?
Yeah. So again, I take care of the thyroid population, not the celiac population. But my reading of the current celiac guidelines is that first-degree relatives of individuals who have celiac, testing for celiac disease is recommended, certainly in children, and I believe also in adults. In terms of exactly what the screening is, to be 100% honest, I would have to look and see kind of what's the current recommendation, whether it's a IgA, tissue transglutaminase. But from my perspective, as a thyroid doctor, I'd say, yeah, if your child has celiac disease, siblings probably should be tested. How often, I don't know. Some people every couple of years, I think, is general. But I believe that recommendation is also similar for adults with celiac disease. First-degree relatives should be aware, and screening is recommended for celiac.
And then the flip question for Jim is whether siblings of people with thyroid autoimmune disease, should be checked as well.
Yeah, well, it's a good question, and when people press me on that with, well, should my children be screened? I typically say, well, make your pediatrician aware of this, and if they have any symptoms or findings that could be consistent with the presence of thyroid disease, then perhaps yes. But as Ari pointed out, I mean, the current thinking on how is it that in a genetically predisposed individual we trigger the development of anti-thyroid antibodies and the inflammatory process. I mean, one of the theories is that, well, you get some sort of virus that gets taken up into the thyroid, and then it causes a little bit of damage and opens up some tissue to be reacted to, and you're off and running if you are genetically predisposed to this. And I agree with Ari 100% that there's people out in the population, and I think the figure is somewhere around 10%, that are actually TPO antibody positive, but completely asymptomatic with normal thyroid function. And what do you do with them? Well, I suppose you can check their TSH every year. You're certainly not going to paralyze their immune system to try to wipe away their antibodies. In patients who are put on low gluten diets, it's extremely variable as to what happens with the antibodies. A couple of the studies seem to look like the antibody levels went down a little bit, but the thyroid function didn't change at all, whether they were euthyroid or actually hypothyroid. So the only real intervention there is observation, and I think being conservative, and only treating people that really meet criteria for the initiation of treatment.
And then there is a question that if we can reassure the audience about if there is a correlation between celiac disease and thyroid cancer. And either one of you can open that, or both of you can answer that.
Not that I'm aware of.
Yeah, I think I'd answer that in the Q&A as well.
Yeah.
To my knowledge, I'm not aware of any association between celiac disease and thyroid cancer.
And then there are questions regarding who should treat thyroid dysfunction in the context of celiac disease. Should it be a specialist, or should it be the primary care doctor? And there might be different perspective from the pediatric or adult standpoint. So why don't we start with Jim for the adult patients, and then Ari will offer his perspective on pediatrics.
So what was the question? Who should treat the celiac, or who should treat the thyroid condition?
The thyroid in the concept of celiac. Should it be a specialist, or should it be a primary care doctor?
Yeah, we just had that discussion in our faculty meeting just an hour ago. And the reality is we're happy to see someone in consultation, review their case, make plans to get them stabilized and squared away. But at the same time, it's probably not necessary to be wedded to an endocrinologist for the rest of your life once everything is squared away and the primary care doctor can then pick up the control. Now, that being said, what I don't know is what happens with the celiac. Are the primary care doctors following that with the nutritionist to make sure that the low gluten diet continues to be enforced, or are all of the celiac patients being followed by gastroenterologists? I simply don't know the answer to that question. But at the same time, we typically would say, we're happy to see you in consultation. Interesting combination of celiac and hypothyroidism. Your antibodies are indeed positive, so it's autoimmune. Let's get you started on some thyroid hormone replacement. Oh, look at that. It's been 6 months or a year or 2 years. Everything's nice and stable. Just keep up the good work. You can return to your primary care doctor.
Ari, what's the perspective in the pediatric world?
I totally agree with Jim. The only thing I would say is in pediatrics, I think it's a little, primary care doctors generally are not that comfortable managing hypothyroidism in kids, part maybe because it's so important for growth and development. So typically in children with hypothyroidism, general pediatricians will usually send them to a pediatric endocrinologist. Not that they couldn't do it in primary care, they're just not as comfortable. But certainly when they get to be adults and I'm ready to transition them to adult care, I usually say, you've been doing fine, just see your primary care doctor. They can check your TSH, adjust your levothyroxine a little bit if needed, and see an endocrinologist if it becomes more complicated, if your doctor thinks you need to.
And Jim, this is your field. There are two questions, one regarding grapefruit while taking levothyroxine, not grapefruit juice, it says grapefruit, and another one, herbal decaf tea. Do you see any problems with those?
Okay, so I can answer the first question. It's been reported that ingestion of grapefruit juice with levothyroxine retards its absorption. I don't understand the mechanism entirely on that, but I do know that that association is in just about every table of things that interact with levothyroxine. Very specific question about decaf herbal tea. Not sure. As you know, our friends from Italy have had their patients ingest their thyroxine with coffee and have demonstrated that it leads to malabsorption. I've never seen a study with decaf.
Sicilian espresso coffee.
Yes,
So
yes.
A variation there.
Yes. And Sal told me that he got it right out of the machine in the waiting area. So it wasn't specially brewed. It came out of a machine. But at the same time, I don't think I've ever seen a study about decaf herbal tea. But I usually say to patients, why mess with stuff like that? Why don't you just take it fasting with water only 60 minutes before your breakfast? That's probably the optimal way to do it.
For the organizer, do we have time for one question?
Yes, you do. Thank you.
This is a very critical question, and I would like to hear everybody. So there is a question about the normal range for TSH and how the current 4.5 or 5, whatever, highest level of the normal range could be too high and miss people who have clinically significant thyroid dysfunction. And that's an important topic because a lot of the population will have that level. And so let's see what your perspective.
Well, Ari, can I go first?
By all means.
You know, I would say that based upon the NHANES data that Marty Sirks and Joe Hollowell developed, they were able to isolate a population of people. Now, I think NHANES starts at age 18, so I don't know all that much about formal studies looking at this in pediatric populations. But at age 18 and over, for every decade, they were able to show in patients who were free of thyroid disease, antibody negative with no family history. So let's call them as clean a population as you can imagine. That for those 20 to 30, perhaps an upper limit normal of 3.6, 3.7 might be quite reasonable because cross-sectionally, that's what that study showed. But when we got up over 70 and 80 and 90, it was clearly up into the 6, 7, 8 range for people who were basically assumed to be completely normal thyroid function. So there is a spectrum, and the younger the patient, the more suspicious I would be of someone with symptoms who has a TSH of 5, 5.5, as to perhaps that does represent actual thyroid disease.
Ari, what about the pediatric population? Do you worry about, or you people who are children who are TSH is 3 or 4?
Yeah, this used to be, I'm sure, similar to the adult world, but there used to be a lot of debate about this, particularly in the congenital hypothyroidism world. Kids we know have hypothyroidism. Do we have to make sure their TSHs get down to the lower part of the normal range as opposed to the upper part? And at least in terms of the outcome data that we have, do they grow up okay? Do they grow and develop and have normal cognitive function? It doesn't seem to make a difference. Having the TSH be in the what we call the normal range, up to 4.5 or 5, seems to be perfectly fine. It doesn't quite get to the question about what about these other symptoms that people might have when their TSH is what we call normal, but in the upper part, and what does that do to? And that's a long discussion that you guys have alluded to about are those multiple related questions? Are those symptoms really related to the thyroid? Are they related to something else? There are questions about genetics, and do certain people respond better to addition of additional thyroid hormone? Most people probably do not, but maybe there's a subset who would. And that's a whole other discussion, which I think that I would say in general we do not worry about it. We use the normal range generally is acceptable for clinical practice.
So to reinforce that with adults, there are multiple controlled studies looking at very, very precise interviews about symptoms, and having a low normal TSH, a mid-normal TSH, and even slightly elevated TSH, where it makes absolutely no difference in the objective measurement or reporting of symptoms. So just because your TSH is 5, that probably eliminates thyroid from your picture if you're 65 years old. It's something else. And in prospective studies, especially among older people, when they had so-called subclinical hypothyroidism with a mildly elevated TSH in the 5.5, 6 range, but normal free T4, the initiation of thyroid hormone with a suppression of TSH down to about 2 had no impact on their symptoms whatsoever. There may have been minor and interesting impacts on cardiovascular parameters like cholesterol or something along those lines, but those were minor. But it does nothing for symptoms whatsoever. I usually say, let's get over this and have your primary care doctor figure out why you feel this way. Because if you spend all your time spinning your wheels in the thyroid world, you're probably missing out on life.
Thank you for that. So I want to thank the speakers for giving us their time in this wonderful webinar. I want to thank the audience for participating with very thoughtful questions, and I'll turn it over to Chris for the final remarks.
Well, thank you, Dr. Barbacino. And again, thank you to all of our presenters and our attendees for your participation. We hope you found this webinar to be educational and helpful. Please join us for our next webinar on November 15th, 2023, where our topic will be building a strong foundation, celiac disease, and bone health. You can now register for this event at the National Celiac Association website, nationalceliac.org. Until then, we are stronger together. From all of us here, we'll see you next time, and thank you for your continued support.